We have our next speaker, our eminent Dr. Mahesh Gopalkrishnan, who's a Senior Consultant Vitreoretina Service and the Head of the Department of the Vitreoretina Services from Giridhar Eye Institute, Kochi. Again, a highly respected surgeon nationally and in the state of Kerala. And he is going to be talking on another very important topic, PCV angiographic discussion. On to you.
Thank you, madam. I'm audible now?
Yes, yes.
Yeah. So I will be talking on the angiographic patterns of PCV, mainly ICG angiography, because fluorescent angiography does not have much of role in diagnosis of PCV. And OCTA I have not taken because I thought this was a basic course. So in fact, PCV was coined by Yanusi in 1984 when I was in my school. So after 40 years also, we are having that term, and even though it has been modified, redefined by a lot of people, which included the branching choroidal vascular network as well as polyp. And the location also has been found to be in the macula or peripapillary or periphery. So there are some changes in the polypoid choroidal vasculopathy epidemiology and types, but the basics remains the same. And it has network of vessels, polypoidal structures, and PED overlaying the polypoidal structure. So this is the basic thing in a PCV presentation. So it is supposed to be more in females in Europeans, but in India we see more males also. And clinical presentations vary: subretinal hemorrhages in a hemorrhagic type, then exudative type is there, where a lot of exudations are there. Then serosanguinous, you can see a tinge of blood also. And here the orange lesion is there, polyp, serosanguinous type. Then mixed type, exudates, hemorrhage, everything together. So these are all different types of PCV clinical presentations. So ICG angiography can demonstrate, this is the gold standard in diagnosis of PCV. It can demonstrate small cluster of numerous hyperfluorescent dots. Polyp can be large aneurysmal dilatation, grape-like clusters, and large vessel deformations can be there. So these are some of the examples. This is one of the early camera-based ICG, where we can see in the, even if there is blood, you can see a string of polyp and a bunch of polyp in the just next to the fovea, infratemporal to the fovea. So polyp can be clearly demonstrated even with the in the presence of small hemorrhages. It can be subfoveal, where our treatment is little more difficult, but extrafoveal and peripapillary are amenable to thermal laser even with very good results. So, and I will show you some of the examples. This is the bunch of polyps you can see in the temporal at the edge of the hemorrhages here. And this is late phase of ICG angiogram. This is another one, the peripapillary. Even clinically, you can see that orange lesion where there is a bunch of polyp in ICG. In many times, when there is a large subretinal hemorrhage, sub-RP hemorrhage, at the notch of the PED, you may be able to see a bunch of network of polyp. So this is peripapillary polyp, just above the disc, very common presentation. And sometimes it can be seen at the edge of the pigmentoepithelial detachment. So this is one difference of ICG hotspot compared to the RAP, where the hyperfluorescent spot is at the center in RAP, but here it is at the edge at the notch. So it is very useful. ICG is very useful in post-treatment, post-thermal laser. Here you can see the initial picture, pre-treatment polyp in the just extrafoveal, juxtafoveal area, and post-treatment ICG shows disappearance of the polyp. So that is very useful in, this is another case, peripapillary polyp, and after injection and thermal laser, the exudate have disappeared, and even the ICG follow-up shows that disappearance of polyp. Another one, it looks like tributary vein occlusion, but FFA is not very conclusive, but you can see in ICG string of polyps. So this is another one. You can see light that polyp in multiple areas in the center of the exudates. So these are some of the cases. Initially, you can see this patient had a serous detachment, even though there was a polyp. Initially, anti-VEGF was tried, but there was no response. So 2014, 15, 16, and in spite of all these injections, polyps were not going. And after switching to photodynamic therapy, the polyp disappeared. So the angiography closure is very important in many of these cases where it is more with photodynamic therapy. So this is another case where there is a serosanguinous detachment with polyp. After injections, we did the ICG again, and it showed a bunch of polyp, cluster of polyps. And then after doing the PDT, you can see the ICG complete disappearance of the cluster of polyp. So this and later, after 2 years, it started recurring. The branching, started recurring. So this is after 2 years, the branching vascular network is again the tip of the areas are coming and activated to new polyp. So repeat photodynamic therapy was done, and after that, you can see again that bunch of polyp has disappeared. So the PDT should, when you do PDT, even though it is not available now, it should treat both polyp and branching vascular network. And BVN can be identified by double layer sign in OCT and OCTA. I am not discussing that area. And recurrence is very common in PCV after many years with new polyps and the worsening of branching vascular network. So this is another case where there is a bunch of polyp with double layer sign and the thumb-shaped PEDs. And later, the new polyps can appear. Some of the examples I will show you. This is a case where the right eye is having a pachychoroid spectrum, where the right eye is having leakage like a PCV. I mean, leakage like a central serous retinopathy, but no polyp is seen. But in the left eye, you can see the above the in the nasal part of the macula, you can see a bunch of polyp here in this area, and you can get in one eye PCV and the other eye central serous chorioretinopathy in many of these pachy spectrum. So this was another case. Right eye is already a scar. Left eye had a CSR-like leak in fluorescein angiogram way back in 2010. And later, after 5 years, patient developed a subretinal hemorrhage. At that time, there was a polyp at the subfoveal region.
You have 1 minute remaining, sir.
Yeah. So this is after treatment, there was disappearance, and patient had later, after many years, again recurrence of the polyp. So at that time, anti-VEGF injection was. So this is another patient. My old patient actually initially had a photodynamic therapy. That vascular network is recurring inferiorly, and they later superiorly. Over many 8 years, you can see the angiography. 2010, 13, 14, and the recurrence of polyp can be seen beautifully in angiography. The other aspect is peripheral polyp. In many of this is we can document this peripheral polyp by wide field angiography. Many cases where there is a hemorrhagic choroidal detachment in the periphery, you can get this peripheral polyp in ICG. The treatment depends on the involvement of macula and other factors. So sometimes it is thermal laser is possible in this area. So this is a peripheral polyp in you can the angiography, ICG angiography, you can see the bunch of polyp. So another this is just I'm finishing a ring of polyp around a branching vascular network and post-treatment resolution. So this is pulsatile polyp. In fact, you can see that area. There's a nice pulsatile polyp. I have a collection of around 5-6 cases. We treat just like any other polyp, and we have not seen any massive hemorrhage in these cases. So even though the ICG angiography is not necessary to diagnose a polypoidal choroidal vasculopathy, and many of the OCT biomarkers can be useful in detecting PCV, ICG is the gold standard for diagnosis of PCV, and polyp and BVN are very important, and it is ICG demonstrates the post-treatment picture very useful. It is very useful in the management. OCT biomarkers are equally good, but for PDT and thermal laser, ICG is mandatory. Thank you for the kind attention.
Thank you very much for a very detailed talk, Dr. Mahesh. And has Dr. Moona Binde joined us?
Invitation from Moona madam. Yes, madam.
Yes, thank you, Mahesh. That was a very nice demonstration of the ICG changes in PCV. Probably I would request you to explain to the audience how often you would repeat an ICG, since you've confined your only to ICG. How often would you repeat an ICG? And in the post-PDT, we are, I think, now considering ourselves as the post-PDT era, where we know the BVN does not disappear with our anti-VEGF treatment. What are the ICG features that tell you that, yes, the patient is responding?
Yes, madam. Actually, we try to do ICG in all AMD PCV suspect cases initially. And post-treatment, if we are, the ICG is most useful if you do a thermal laser or photodynamic therapy, where you can aim where to give the laser. So that is many cases, extrafoveal polypendal, they respond beautifully with thermal laser. So I try to do ICG in all cases initially, and then if you want to see the response to treatment and you want to, thermal laser or PDT, I repeat ICG after 3 months. But in this anti-VEGF era, now we don't have PDT. So only if I suspect a peripapillary or extrafoveal polyp, I am doing ICG regularly.
And we also need to remember that the BVN would persist, and when we do focal treatment, very often we treat only the polyp.
Yes.
May find that some other tip of the BVN may leak at a later date. So it's important to delineate the entire extent of the lesion.
Yes, madam. That's what one case I showed. In 3 areas it came, and for over 10 years.
Yeah. And another point, probably you did show it in some of your cases. One of the patients, the choroidal circulation looked fairly okay, other than the PCV net. Whereas in another one, there was a lot of leaky choroid. We saw the dilated choroidal vessels. Did see some amount of choroidal hyperpermeability. So what tips would you give to people if they were to identify this, and which phases of the ICG would you be looking for?
Yes, madam. Actually, the polyp and branching vascular network, the polyp will start little, not at the early phase like a wrap, where the hyperfluorescent spot is seen in a very early phase. So here, the mid phase is more useful to identify the branching vascular network and polyp. I think.
And we'd be also looking for, if you do, even if you don't have access to wide angled ICG, if you do an all quadrant ICG, you may see the dilated vortex veins. And in the late phase, you may see the leaky choroidal vessels, indicating that these are patients probably belonging to the pachychoroid spectrum. Would either George or Anand want to make a comment? This very nice talk.
Thank you, Dr. Mahesh, for a nice talk and covering ICG. I just want to add that you already brought in the point that this ICG mimickers of PCV also, because we talk about first 1 minute appearance of the hypercyanescent nodule with a halo of hypocyanescence, and along with BVN, that is a classic, and first 6 minutes of ICG angiography as a diagnostic sign for polypoidal lesion on ICG. But we have to keep in mind 2 or 3 mimickers of PCV, polypoidal hyperfluorescent nodule on ICG. One being wrap lesion, which you have already mentioned, which happens on the center of the PED and also appears in type 3 CNVM overlying the PED. Second, that also can produce submacular hemorrhage. Another would be a aneurysm, can produce submacular bleed or associated with intraretinal, subretinal or preretinal hemorrhage. So that also, the angiography is very important, both fluorescein and ECG, to pick up the lesion, diagnosis of RAM. Another is when you have concomitant microaneurysms of diabetic retinopathy, should not be confused for a CNVM, which might nodular microaneurysms may appear as small nodular hypercyanescent lesions, even on ICG. So these are what I would like to add. And to what Dr. Moona madam has added, now since there is a trend of non-ICGA diagnostic modalities, and we are treating with only with anti-VEGF therapies like brolucizumab or aflibercept, it's very important to keep in mind that the polyp inactivation happens on OCT, but it's good to see whether the polyp is still active or not, because if you have pulsatile polyp, they may just present with large submacular bleed if you take it for granted that polyps have regressed based on the OCT signs. So this is what I would like to add to this.
Yeah. Just to add to what George said and Dr. Puna said, one little more masquerader would be a choroidal knuckle, which I think George has painstakingly elaborated long back in the past. So that's another thing that that's a rare entity, but that is there for sure. And yes, as you know, we've seen over the last maybe few years, there is this trend, and APOIS, the Asia Pacific Ocular Imaging Society, has also highlighted the non-ICG characteristics. We've heard Dr. Jemmy Chung in various fora talk about how they are now relying and their sensitivity, specificity seems to be high with these non-OIS, non-ICG criteria. Basically, sub-RP ring structures, the sharp peak 50 EV, and I think that RP elevation which they see. So I think that is how. I know you're reliant on ICG, but are you also in your practice now tending to move towards this more progressively, especially as Dr. Muna mentioned on follow, where we would not want to do too much of invasive angiography?